So we're pleased to have a number of speakers with us today, and they're going to share what one should be expecting at the beginning of their cancer journey with CancerCare Manitoba, all with the goal of continuing to close the care gap between care providers and patients. We're aware of folks are going to continue to enjoy the event, but we'll get started in the interest of trying to stay on schedule. So my name is Dr. Donna Turner. I'm an epidemiologist and the Chief of Population Oncology at CancerCare Manitoba, and I'll be the moderator and host for the session for this evening, and look forward to hearing from all of our presenters and facilitating the Q&A later. So first, I would like to start with the important acknowledgement of the land that we are on. So we at CancerCare Manitoba acknowledge that between 1871 and 1906, treaty commissioners acting on behalf of the Crown signed 7 treaties with First Nations leaders in what is now called Manitoba. This land on which we gather is the traditional territory of the Cree, Dakota, Dene, Anishinaabe, Ojibwe, and Ojibwe peoples, as well as the homeland of the Métis Nation. Now, before introducing our speakers, I'd like to review a few housekeeping details for our Zoom webinar tonight. So many people, because of the pandemic, are now maybe familiar with Zoom, but Zoom webinars may be new to some of you, so we'll just go over a few details. So in the Zoom webinars, attendees aren't able to unmute or turn on their cameras themselves. We're going to be using the Q&A button, which you can see at the bottom of your screen. You should see a number of icons down there, and in one of the 2 speech bubbles, there's one called Q&A. And when you click that button, it should open a window where you're able to submit your questions. So please note that all the submitted questions won't be viewable to other attendees, so only submit one question at a time, and we'll just make sure that we get to them. We will do our best to respond to all the questions that we get during the Q&A period at the end of tonight's session. You're free to answer your questions in the Q&A throughout the presentations as they occur to you, but again, we'll be doing that moderated Q&A after all the presentations are finished, just to make sure that we make sure that we get through all the presentations. You'll also see there's a chat button down there, but don't enter comments in there. You're not going to be able to, in fact. We will be including links to other information in the chat throughout the webinar, so keep your eyes peeled to that. And an important note is that the Zoom session is being recorded, so please keep in mind that the question you submit may be read out loud, and please don't ask any questions which you're not comfortable having included in a recording. And as a general disclaimer for questions this evening, please keep in mind that our presenters will not be able to speak to specific or personal medical questions that you may have. We highly encourage you to connect directly with your healthcare team at CancerCare Manitoba, your community cancer program, or your primary healthcare provider if you aren't connected with CancerCare yet. So any medical questions you have really belong with you and your healthcare provider. If you're new to the cancer journey and you're not sure about any aspect of what's happening, you can also talk with a nurse navigator, and we'll be providing that contact information in the chat and at the end of tonight's session. All right, so let's get on to the exciting part. We are thrilled to have 6 incredible leaders from CancerCare Manitoba speak tonight about what their departments and programs offer to patients and how it looks to start with their respective programs. So first, we'll have a message from Dr. Navaratnam, the President and CEO of CancerCare Manitoba, who will provide us with her opening greetings to set the tone of our session tonight and share her perspective on the importance of closing the care gap.
Good evening and warm welcome from CancerCare Manitoba. I'm so pleased to see all of you joining this webinar. This is organized by us as part of the World Cancer Day program. The World Cancer Day has the theme of closing the gap. The cancer services have made so much progress and more cures are seen with cancer diagnosis, and more people are living with cancer. Yet, there are gaps that we need to close. For example, equity. Is everyone in this province are able to get equitable care? Are we able to bring the research findings to you, to patients, to bring the high quality cancer services? So those are some of the gaps we want to continue to work on. But today or this year, the theme that we chose for closing the gap is the information. We wanted to provide information to all of you so that you're empowered, you have the right tools to go through this cancer journey. So information is always powerful. Knowing what to expect, knowing what's going to happen, what type of treatment that you're going to receive, having all this information as someone who's going through cancer or your family is very important. So that is the purpose of this webinar today. So we have such a strong clinical team leaders are going to speak to you. They're going to talk to you about what is surgery in cancer, how is radiation help with cancer, and how is chemotherapy help with cancer. So you will hear from all three specialists. And also for children, for pediatric group, we also have the head of the pediatric team is going to talk to you. Big part of cancer journey is receiving emotional support. So you will also hear from the clinician on how to receive emotional support during your cancer journey. So please engage, listen, and ask questions during the question and answer period. And even after the webinar, please engage with us. Engage with your healthcare providers. Ask all the right questions so you have the full information about your cancer, about your treatment, so that you could take this journey much more comfortably.
All right. So with very great thanks to Dr. Navaratnam for her opening remarks and setting the tone as we talk about closing the care gap. So just as a reminder, as we get going, if you have questions, as you think of them, please put them in the Q&A and we will answer them at the end of the presentation. So to start us off, we will be hearing from Dr. Pamela Hebbard, who will be speaking about what is many patients' first step in the cancer care journey, which is surgery. Dr. Pamela Hebbard is the head of surgical oncology at CancerCare Manitoba, and I'll now turn it over to her. Dr. Hebbard.
Thank you, Anna. It's great to be here, and hi to everyone who's joining in this evening. I'm happy to start things off. I'm a practicing surgeon, so of course I think my specialty is going to be the most important one that you're going to hear, although my colleagues that you're going to hear afterwards are going to say the same thing as well. Surgery is really important into the treatment of cancer, and many patients with a cancer diagnosis will meet a surgeon at some point in their journey. In fact, for most of our common cancers, so those would be things like lung cancer, colorectal cancer, breast cancer, prostate cancer as our most common cancers, all of those cancers, the core of treatment is surgery to remove the tumor. We oftentimes do other things on top of that, but surgery has to be part of your treatment plan if that treatment plan is to have the cancer cured. Unfortunately, for all cancers, not all cancers can be cured. And so in an incurable cancer, surgery may or may not be part of the role of things that happen in order for patients to have improvement of their symptoms and maybe live longer. So when we look at cancer and when are you going to meet this surgeon, oftentimes that's going to start in an office somewhere in a consultation room. And this is a typical one for us here at CancerCare. And you can meet surgeons in different parts of your journey. For many patients, they're going to meet a surgeon before they even know that they have cancer and there's just a suspicion. And the surgeon will be part of the team that does the workup. So we know what type of cancer and what stage, and oftentimes we'll do the biopsy. There are other specialists that do biopsies. In particular, we have radiologists, gastroenterologists, respirologists who all do specialized biopsies, but many common biopsies are done by surgeons as well. So you may meet your surgeon before you have a cancer diagnosis, or you may meet them and already know that you have cancer, and you're going to meet them to talk about surgery as part of the treatment plan. So where is that going to happen? We can move forward to the next slide. That's going to happen all over the province. So unlike the delivery of chemotherapy or radiation, surgery happens mainly in hospitals, and hospitals all over the province. And outside of CancerCare Manitoba itself. So you'll meet surgeons oftentimes in a care facility that is closer to home, and they will help to make that workup and decide whether or not you need surgery. For many common types of cancers, that will be done in various community hospitals as well. But for very advanced cancers and complex cancers, many of that is centralized to the Health Sciences Center in Winnipeg, which is the other place I work outside of CancerCare as well. And so complex cancers are oftentimes rarer cancers or cancers that need a bigger team in order for the surgery to go off successfully. One example of that is cancers of the head and neck. They tend to be very complicated to operate on. So you actually have more than one surgeon doing that surgery on your day of surgery. One team that's taking out the tumor and one team that's actually reconstructing or fixing the defect so the patient can get back to regular life. So where your surgery happens might be in a variety of different places across the province, depending on what kind of care you need. If we go on to CancerCare as well, then some kind of things are done in CancerCare. So this is a picture of our procedure room, or one of the two major procedure rooms that we have. And many biopsies for certain cancers are done. We do a lot of lymph node biopsies for cancers called lymphoma. Melanoma, if it's early, just needs an excision of skin, and we do frequent biopsies of things like that here. So you might actually have your treatment in what we call a minor procedure or minor operating room, or you may have your biopsy done in a place like this. Various hospitals around the province will have procedure rooms like this as well. So you don't necessarily always have to come to CancerCare for a minor procedure, but for certain types of things you will. Another example of that is our other procedure room does prostate biopsies. And for patients who have suspicion of prostate cancer, they oftentimes come to a specialized procedure room, somewhat similar to this one, to get their biopsy done. And then if you need an actual full surgery, you're going to end up in an operating room. And this is one of many operating rooms across the province. It'll have a variety of different equipment, all of which will look a little bit foreign and different. And there'll be a whole bunch of people in there. An operating room usually has an anesthesiologist and maybe an anesthesiology assistant, 2 or 3 nurses, and the surgical team will normally include your main surgeon and at least 1 assistant. For complex cancer, and some of the cancers that I do, I oftentimes have a team of surgeons. So there might be 2 or 3 surgeons doing various portions of that surgery as well. So many of you may have had surgery for all sorts of reasons, whether or not it's for a cancer or for appendicitis. But this is what a typical operating room might look like. So finally, it's important to know that surgery does happen all across the province, and it's being done well and expertly. And you'll be taken care of in whatever facility is the best suited to where you live and also what kind of care you need. This is an example of the Boundary Trails Hospital, and they do a variety of cancer surgeries. So many common colon cancers and breast cancers can be treated at this place, for example. And just know that even though that building doesn't have CancerCare Manitoba, surgeons work within a network and are very tightly liaised with surgeons who are physically at CancerCare, as well as other people like the medical and radiation oncologist. And that information flows back and forth quite seamlessly so that your care is being taken care of wherever it needs to happen. For many patients, their journey will start with surgery and then it will go on to other treatments like radiation or chemotherapy. And you're going to hear about those next. And you'll know that your surgeon is part of the team that has that overall vision of what you need in order to have your cancer treated. So maybe at this, I'll hand it back to Donna. Thanks.
All right. Thank you very much, Dr. Hebbard. So that's an excellent introduction to surgery. And as Dr. Hebbard said, really common starting place for lots of patients. So next, we'll hear from Dr. Leonard Minuk. Dr. Minuk is a hematologist and the head of the Department of Medical Oncology and Hematology here at CancerCare Manitoba. And he'll be sharing what may be the next step for many cancer patients in their treatment, which is receiving systemic therapy, such as chemotherapy. Welcome, Dr. Minuk.
Thank you, Dr. Turner. And Dr. Hebbard and I will talk at some point in the future about what is in fact the most important component of cancer treatment. As Donna mentioned, I am a hematologist, which means I personally treat individuals who have cancers of lymph nodes and the bone marrow. So as was mentioned in the previous presentation, individuals' cancer treatment mainstay is often surgery, but in some instances, chemotherapy treatment is part of their care as well. The patient journey towards systemic therapy or chemotherapy often begins at one of these 4 sites. These are places where you would meet a medical oncologist or hematologist in person. 3 of those sites are in the city of Winnipeg. So on the top left, that's the McCharles site at Health Sciences Center. On the bottom left is the Taché site at St. Boniface Hospital. And on the bottom right is the Cancer Center at Victoria Hospital. And at the top right is the Western Manitoba Cancer Center, which is in Brandon. I can have the next slide, please. So as was very well shown at the introductory video, these are our cancer navigators. And individuals who've been referred to CancerCare Manitoba, often their first point of contact will be an individual employed by our referral office, which may be one of these navigators. And they assist our patients in navigating through the cancer journey, which can often seem a bit complicated at the beginning, whether it be going between various tests and appointments. Next slide. Excellent. So prior to an appointment with a medical oncologist or hematologist, you would likely be sent for a number of tests. This could involve blood tests or sometimes involve imaging tests, such as a CT scan or other imaging tests. The purpose of these tests are, one, sometimes to provide us with staging information, meaning so that your oncologist will know which locations in your body the cancer may be, but also to determine some information that can help us guide discussions about prognosis, as well as help us understand an individual's ability to take certain chemotherapy treatments that we would use for treating cancer. So the next stage is actually meeting your oncologist, and typically that meeting occurs in person in an exam room shown on the left. Occasionally for individuals who live remotely, especially outside of a large center, we may see you by telehealth. So on the right is a telehealth room, which has a video screen where we can still speak face-to-face for that first appointment. A number of things will occur during that appointment. A physician will talk to you about your medical history and ask a number of questions about your cancer diagnosis. They will also likely, when in person, perform a physical examination. And then they will review all of the tests that have been done previously, whether that be biopsies, blood tests, or imaging tests. And with this information, There'll be some disclosure about details of the diagnosis, so what is the particular type of cancer, some discussion about staging, so where in the body or how advanced is the cancer, and with that, a discussion about prognosis. And then the bulk of the discussion, so most of our time, will then be discussing how we might then treat the cancer. So at this point, we're seeing individuals after they've had perhaps their surgical treatment, and we're going to talk to them, at least in my instance, about chemotherapy drugs. So chemotherapy can mean a number of different things, and there's far too many chemotherapy treatments to talk about than we could fit in today's presentation. Sometimes that chemotherapy can involve what people know as traditional chemotherapy drugs that are given as an intravenous injection. Sometimes that chemotherapy can involve more targeted treatments, and sometimes it can involve treatments that actually affect the immune system, or what we call immunotherapy. I find that individuals' perception of cancer treatments and chemotherapy are sometimes based on some older stereotypes, and the belief is that all the drugs we give are harsh chemicals that cause hair loss and severe nausea or vomiting. But we have come quite a long way in chemotherapy treatment since the early days, both in terms of supportive care medications we can give people to help prevent side effects like nausea or vomiting or others, as well as more targeted treatments that sometimes don't come with the same kinds of traditional side effects. As well, especially recently, more of our chemotherapy drugs are actually available in pill form. So some individuals would not even be getting intravenous injections of treatment. We have quite a wide network of CancerCare sites throughout the province that are capable of actually physically administering chemotherapy drugs that have to be given by injection. So while your medical oncologist or hematologist may be physically based in Winnipeg or Brandon, and maybe directing your treatment from Winnipeg or Brandon, the actually delivery of those chemotherapy drugs can be done throughout the province. And as you can see from this map of Manitoba, the little red circles are all community cancer sites or community cancer programs, where both we have the nursing staff and physical infrastructure for delivering intravenous chemotherapy drugs, as well as a network of family practitioners who have been trained in the supervision of chemotherapy drugs that can actually directly supervise these treatments throughout the province. And I think that's all from me.
All right, thank you very much, Dr. Minuk. That's a very good overview of all the things to think about with the systemic therapies, including chemotherapy, that people may encounter as they are going through their cancer treatment journey. And it is great to see, and as this slide shows, the different places where patients in Manitoba are able to receive cancer treatments, and it's really quite diverse and good to know that it's not just in the major centers that people have to attend. So let's jump right into the next type of treatment, which is radiation therapy. And we're going to hear from Dr. Rashmi Koul, and she'll be speaking about radiation therapy. She is the head of radiation oncology here at CancerCare Manitoba. And I'll turn it over to you, Dr. Koul.
Thank you, Dr. Turner, and thank you, Dr. Hebbard and Dr. Minuk, setting up the stage. As you know, I'm a radiation oncologist by this time, and I practice male genitourinary cancers, prostate and bladder, and I'm the only female there, so that's pretty cool. So if your doctor has determined that you are eligible for radiation, as Dr. Hebbard said, that most often it is referred by the surgeon or by medical oncology chemo doctors to us. By this time, most often we have all the information which we require, a bunch of blood tests or all the imaging which Dr. Minuk showed you those pictures. Your oncologist is going to meet you in a similar examination room as already you have seen on the screen with my previous friends. They will go over all the test results with you, and similarly, they will stage each patient because there are different kind of treatments available. So your oncologist will go over everything in detail, and if it is deemed that you're eligible for radiation, then whole focus will be on radiation. You will be given contact information of your clinic nurse so that you can always call them back just in case you forgot a question or your family had some other question which we didn't have a chance to discuss. So that option is always open. They usually will return the phone call by next business day. We have our outpatient radiation oncology clinics. Majority of them are at McDermott Avenue, CancerCare Manitoba, McCall site. We do have some clinics outpatient at St. Boniface Taché, as well as Brandon at Western Manitoba Cancer Center. However, the radiation machines are only housed at McCall site and in Brandon. We have a total of 7 machines, 1 in Brandon and 6 out in Winnipeg for Manitobans available to us. So once in that appointment, the favorite question always comes up once radiation has been decided, that how many fractions we will receive. And that's where the whole discussion happens. Your oncologist is going to look at all the parameters they need. It would be your biopsy results, your CT scan, bone scan, bunch of blood work, your past medical history, if you ever had cancer in the past, and then they will come up with a plan. They will let you know what fractionation, what schedule you will be coming to CancerCare Manitoba, either in Winnipeg or at Brandon. And we have different schedules available. So we look at many parameters. So not everybody will have same schedule. You might have person sitting next to you will have different schedule than yours. For example, in prostate cancer, we may have Mr. Smith having radiation once a day, Monday to Friday, Saturday, Sunday, no treatment for 5 weeks. Then there will be Mr. John who will have similar treatment, but only for 4 weeks. And then will be Mrs. Smith, she'll have treatment only for 1 week. So all these information will be provided to you on that day. And next slide, please. Once that is determined, the most important appointment will be what we call marking appointment, tattoo appointment, but the scientific name is CT simulator. We actually simulate your treatment. It is custom made for each and every patient in Manitoba. That means we take into account your height, weight, anatomy, even physiology to some extent. It's a CT scanner, and you can see our smiling radiation technologists who work on the SIM. They will scan the area which your oncologist wants to treat. We treat hundreds of patients each day, so every patient gets his own tattoo mark, and that is actually used for lining you up once you are ready for treatment. Next slide. You might get a fancy, some accessories. It could be a mask or a knee rest to make sure that your treatment is safe and smooth. This is actually a historical picture, and I'm very proud to share with all of you that we are first cancer services available in Manitoba since 1930. We had a first machine in 1950s. At that time, it was called Winnipeg General Hospital. We changed the name, and new name came in 1999. So this is an old machine. Next slide. Fast forward, the difference between this machine and present machine, as you can see, aesthetically is pretty fancy. The modern machines are very, very robust. They are actually built on precision medicine. What I mean by saying that is that we try to give maximum dose to your cancer so that we can kill the cancer cells, but try to save just normal structures. For example, in prostate, we want to kill cancer in the prostate. So we'll try to save the rectum, the bladder, the nerves going to adjacent, the hip joints. So different sites are treated on these machines. So these green laser mark on the left are used in where your tattoo mark is to put all them together so that your treatment is executed the way your oncologist wants it to be. We have machines in Winnipeg, as I said, they're very fancy. You feel as if you're in some kind of sci-fi movie. You have to lie still, breathe normally. You'll be connected by audio visual to your team. They'll be hearing you just in case sometimes there's a sick patient who wants to cough, then we will stop the treatment. The basic aim is to lie still so that we can treat you very comfortably and, easy way. So you cannot see radiation, you cannot feel radiation, but it's a strong treatment. So you'll have some side effects, which are definitely a lot better than what machines we had a few decades back. Now we don't encounter that many side effects just because the technology has gotten so better. Similar in our life, you can see the telephone, those black trin, and now to iPhone 14, 15, similar. It's all about precision and all about giving the best to our patients. So we have a dedicated team who will look after your side effects. Your radiation therapist will talk to you every day. We have dedicated RT nurses in Winnipeg as well as in Brandon who will look after just in case you need some extra help. There's some side effect that you encounter or you're uncomfortable with something, they will go over it with you. Once you complete your treatment, you will actually see your oncologist, and on the last day of treatment, you'll be handed out instructions how to take care of yourself, your skin, about dietitian. There are so many things. These are all little, helpful tips for the patient and the family members. On that day, you'll be given information when you will see your radiation oncologist for post-treatment assessment. That's usually 6 to 8 weeks, could be a bit different in various sites. And that time we give for all the treatments to settle down, side effects to settle down, information to settle down, so that when you come back to Winnipeg or Brandon, when you see your doctor, then you are in a baseline position more or less. And you'll be given information to take home, just in case, you forget there's all the phone numbers written down there for you. Next slide, please. So this is a beautiful property, and I have visited. It's Murray House, where our patients who are in the encatchment area of the Brandon, and as you know that radiation could be spread over a few weeks, they can stay there. This information will be also provided to patients through Perry Mountain region once they will have their consultation with their oncologist at Brandon. Last but not least, I would like to say a fun trivia about radiation. Radiation can be given before surgery, after surgery, before chemo, along with chemo, or by itself. So we have different roles depending on what our intent is to achieve in a particular patient. And I think that's all about from my side. Thank you.
All right. Thank you very much, Dr. Koul. So we have covered surgery and systemic therapy, including chemotherapy. Dr. Koul has just talked about radiation therapy, but we're going to change gears a little bit now and talk about another very important facet of work that we do here at CancerCare Manitoba, which is treating children with cancer, and they are treated by individuals who are in our Pediatric Oncology and Hematology department. So to speak to that, I would like to welcome Dr. Geoffrey Cuvelier, the head of our Pediatric Oncology and Hematology department, to share more about the patient journey in pediatrics at CancerCare Manitoba. So Dr. Cuvelier.
Perfect. Thank you very much. Good evening, everybody. My name is Dr. Cuvelier. I am one of the 7 pediatric hematologist oncologists for the entire province of Manitoba. There's our group, and of course we're kids, so the picture on the right describes a little how we like to play as well. We do a very serious business in pediatric oncology, but we always want to make sure we have a bit of fun at the same time. Here in Manitoba, CancerCare Manitoba and the Winnipeg Children's Hospital are really the only sites that treat children between the ages of 0 up to 18 years of age with a number of cancers. Approximately a third of what we will treat are acute lymphoblastic leukemia, which is a form of blood cancer, but we see everything from solid tumors to brain tumors to some rare tumors, lymphomas, and everywhere in between. So what that means very practically is that people really have to come, or children at least, and their families have to come into Winnipeg. And quite often the treatments are long, they are intensive, it's quite likely that you're going to meet a pediatric oncologist very early on in the process, often before we actually know that there's an official cancer diagnosis. We're often involved in the early periods of suspecting the diagnosis. And we're involved from biopsies, investigations, radiologic investigations, and then we often take people along very early on in the process. And we also follow children and treat children not just while they're receiving their particular treatments, but also into the long term. And because we know that children who receive treatments for cancer as young children, what happens is that we know that this can have impacts on their organs and their tissues. And so we actually follow individuals for often 20 years down the road, even once their cancer is in remission and hopefully cured. So we like to be very pediatric focused. The picture you're seeing here is of a child who's receiving their chemotherapy in our playroom. This is just outside of our clinics. Quite often when I'm calling for a patient and they're not yet in the room, I have to go out to the playroom because the kids don't want to leave. We try to make the experience as best as possible for the child as well as for the parent. And in our playroom, you will see people like our child life specialists who work very closely with the families and their children to try to make the experience as best possible. You can go on to the next slide, please. This is just a greater look here at what our treatment or treatment area looks like. This is not actually where the children receive their treatment, but quite often they're in and out. One thing I want to show people is just that you can see that door just up to the top left. That's called our teen rooms. Like most teenagers, they don't want to spend a lot of time around other people. They got a door they can shut off and they can go sit in there and play Xbox or whatever else that they wish to do. So again, trying to make this very patient-centric and focused. You can move on to the next slide. So these here are pictures of how we try to explain complex procedures to young children, often 3-year-old, 4-year-olds, 5-year-olds. That's an example there. We have these dolls and they can go through the CT scanners. And the other picture you see right there is how all the tubes and the scary things that we might potentially do, we try to sort of make it as easy as possible to help to explain to the child and to their parents the sort of things that they're going to be potentially receiving. And so again, one of the things I really want to emphasize is that the first picture showed the pediatric oncologist, but really childhood cancer is a lot more than that. We have really important people on our team who range from our nurses and even our unit clerks who book appointments. And there's some pictures right there of some of the great nurses who we have. These are people who you will see in our treatment room. And they really are experts at some of the pediatric specific things that we need to consider. They're very good at trying to calm down children, sometimes in some very stressful times, and they really become heavily invested in the treatment of all children. Next slide. So one of the things that I really want to emphasize is because we only really do the treatment here in Winnipeg, you can imagine that if you're coming from a place like northern Manitoba, and I should also say that we treat children from northwestern Manitoba or northwestern Ontario, sorry, out to Dryden. We treat children in Nunavut, and we even do stem cell transplants for some kids in as far as Saskatchewan. And so when you come to Winnipeg, it can be a daunting experience. And quite often, families will have to completely relocate for sometimes upwards of a year and sometimes even more. And so this is a picture right here of the Ronald McDonald House. This is the newly designed Ronald McDonald House. If you haven't seen it, it's absolutely gorgeous. There's actually private apartments in here that really are close to the hospital and provide families at least with some sense of normalcy during this very abnormal period. And so people like our social worker on our team become really important to helping families with doing things like helping to get food and accommodations, those things that become really important in this very disruptive period. The only other things that I think I really want to say is that We participate in a large organization called the Children's Oncology Group, and this is really a multi-center. There's about 200 centers in North America that all band together to truly try to learn how to treat childhood cancer. And what this means very practically for Manitobans is that we can actually do pretty much every sort of treatment here in Winnipeg. We do very complex brain surgeries. We do radiation therapy for children. We have one of Canada's only 6 pediatric stem cell transplant programs in the country. There are really only a couple of things that we may ever need to send a child out of Winnipeg for very, very highly specialized therapy, but most of it can be done here in Winnipeg. And I think with that, that's what I will end on. Thank you very much for your time.
All right. Thank you very much, Dr. Cuvelier. This really speaks to some of the very distinct elements of managing children with pediatric cancers and support for them and their families while they go through that treatment journey. So finally, I'd like to introduce our final presenter for the evening, and she'll be sharing another extremely important aspect of the care and services that we provide here at CancerCare Manitoba. In this regard, I'd like to welcome Cheryl Dizon-Reynante to speak, and she's our clinical lead of psychosocial oncology at CancerCare Manitoba. And Cheryl will be talking about the services that are available for patients, but also their family and their loved ones, people that are supporting them, that are provided through psychosocial oncology. So with that, I will turn it over to Cheryl.
Good evening, everybody. Thank you very much, Dr. Turner, for that introduction. So I am here to talk to you a bit about the mental and emotional impact that a cancer diagnosis can bring and the support that is available to you and your family members. So we see that distress tends to happen for anybody in any situation, really, during peak times of transition. And at least a third of the people we see going through the cancer experience encounter psychological, social, employment, or financial shifts and changes and challenges. And this can extend to family members as well. We want to be able to tell you that distress is normal given the situation, but that there are many ways that you can lessen it and learn how to cope with it. So it's very common for people to be diagnosed as well as their caregivers, to feel emotions such as anxiety, frustration, sadness, fear, and a sense of being alone. And so what can help? We find that in general, there are 2 categories of good coping. And so the first that I'll tell you about is problem-based coping. So that is when a situation can be changed or solved, and your fantastic healthcare providers, including the nurse navigators that were featured at the top of the hour, they can help you to problem solve and deal with symptoms, how to get to treatment, questions about treatment, that kind of thing. And so when problems are solved in that regard, angst tends to decrease. But there's also emotion-focused coping. And that's when a situation cannot be changed or quote unquote be solved, but acknowledging and managing the emotions around the situation can bring relief. So the occurrence of treatment can't be changed or solved, so to speak, but there are things that you can do to manage and cope with the anxiety and the distress that can come along with it. And so what psychosocial oncology clinicians do, it's really a fancy term for counseling support. What we can do is provide you with guidance with practical issues, as well as provide short-term counseling sessions for managing the emotional and mental impact that a cancer diagnosis can bring. And so we support not only the person that is diagnosed with cancer, but also their caregivers and family members. And this includes children that are diagnosed with cancer and adolescents and young adults. And in fact, we do have counselors that are solely dedicated to those particular populations. We are located at the 4 cancer sites in Winnipeg. So that is McDermott Avenue, St. Boniface, Victoria Hospital, and the Grace. But we also have wonderful psychosocial oncology counselors that are located in the rural sites across Manitoba. And so counseling sessions are available in person for those that can make it to the sites. However, the pandemic has taught us that we can get a little bit fancier and have now virtual counseling sessions using platforms such as Microsoft Teams, and telephone sessions are also available. Next slide, please. And this is a photograph of the Patient and Family Resource Center that is located at 675 McDermott. And so there's all kinds of books and pamphlets and brochures that are available to patients and families. And even if you can't get down to the McDermott Avenue location, our wonderful coordinator can mail out resources and talk to you about how to access them. So no need to be physically located in Winnipeg to get these readable materials. Also at the McDermott site, we have the Guardian Angel wig and headwear room where people can access wigs and headwear free of charge. Also under our department, we offer webinars such as this that's being provided this evening. And under our umbrella of services, we have nutritional services and physiotherapy. So other than individual sessions, next slide, please, you can see a picture of what may be a typical support group that you can access. And right now they're actually being conducted over Zoom or Teams, but we have found over the last 3 years that even though it's virtual, the effectiveness of support groups and the connectedness that people feel can still happen to the same degree when it's virtual. Whereas when it used to be available in person. So some of the examples of programming is our art therapy, expressive arts group. We have a support group for adolescents and young adults. We have a parents of pediatrics support group available as well. We have a cognitive behavioral with mindfulness class that's available for patients and family members. And in partnership with the Refit Center, we have our Moving Forward After Cancer Wellness program, which incorporates an exercise component. And over at the Wellness Institute at Seven Oaks, we have a yoga program. So how does one access these programs? If you could flip to the next slide, that's great. You can either give us a call on one of the phone numbers that's listed there, depending on your region, but you can also log into the CancerCare Manitoba homepage and just scroll down a bit until you get to our Navigator newsletter, and it will list all of these phone numbers and all of the programs that I quickly talked about. So no need to memorize any of this. It's all on the homepage website, the Navigator newsletter. So you can call us direct. So you don't need a referring professional to access our services. You can call us directly. But if you want to chat about it with your clinic nurse or oncologist, we often get referrals for counseling support through them as well. So that is a snapshot of some of the services that we have available for our patients and family members. So I think that is it for me, Dr. Turner, and we'll hand over the baton back to you.
Thank you very much, Cheryl. That was great. So you can see that there's a lot of incredible resources and services available at CancerCare Manitoba. And thank you very much to all the presenters for sharing how the work that they and their teams do can benefit cancer patients throughout their journey. So we have heard a lot from our presenters, and I'm sure that there's a lot of information that folks are still processing. But we are going to move into a bit of a question and answer period now. And so again, remember that if you have questions, please type them into the Q&A. And I will be monitoring them and we'll bring them forward and you can direct them to a particular presenter. or you can actually just put them out there and I will open the floor to the presenters, or since I know these folks fairly well, I might be able to direct it to them. So the first question that I'm going to ask is, let me see, I'm just going to have a look here. I wondered if Dr. Hebbard could answer a question. So Dr. Hebbard, you mentioned complex cancers, and I wondered if you could give an example of, like, so what's a complex cancer versus a not complex cancer? They all sound pretty complex.
Yeah, that is a great question, and that can be a challenge for even for us, where the line is drawn. And yeah, as well in surgery, we think of surgery as a single entity, but in fact, there's various different types of surgical specialties. Most surgical specialties take 5 years of training after you become a doctor. And if you're a general surgeon, 5 years as an example, you would do colon cancer and breast cancer. That would be considered regular and really core to being a general surgeon. But if you had a colon cancer growing into your liver or your stomach, then you would want someone who is really has some extra special expertise. And that comes to me. I'm a general surgical oncologist. I've done 2 extra years of training just on cancer. So when the cancer is really big, it needs an extra team to do. It needs more than one different surgical specialist. So some of our rectal cancers, you need someone like myself, as well as a urologist and a specialized plastic surgeon in order to do that surgery. So when you get to needing multiple surgeons, multiple organs involved, that's complex. The other complexity is for rare tumors. So all the general surgeons, who are all fantastic, I know them all personally in the province, they see colon cancer routinely day in and day out throughout the year. But a cancer called a sarcoma, which is a cancer of connective tissue, is pretty rare. We only have several dozen of those of the entire province every year. So that's complex because it's a rare tumor. And in order to stay up to date and really plan the right surgery and know all the exact, not only the surgery, but know when to send it to chemo, when to send it to radiation, you need extra training for that. So rare tumors growing into complex things or multiple organs, that would sort of be my bucket list if I had to give you at least an outline.
All right, excellent. Thank you very much. That helps to sort of clarify the language a little bit. So thank you for that. All right, so the next question that I have in the chat is for Dr. Minuk, because it's about chemotherapy. So Dr. Minuk, you talked about how you can do some oral chemotherapies, but how you sometimes have to do IV chemotherapy as well. And can you explain, why are oral drugs used instead of the classic IV chemotherapy?
Yeah, that's a good question. I mean, I think there's an interest over the more recent years to come up with chemotherapy drugs that target something very specific about the cancer. So traditional chemotherapeutic drugs, the older ones that are given intravenously, which we still use very commonly to treat many types of cancers, the way they work is by killing cells that divide rapidly. And cancer cells tend to divide more rapidly than non-cancer cells. The problem with that is that it's not very selective. It can also kill a lot of healthy cells, and that is where the side effects from chemotherapy come. Targeted treatments, rather than non-specifically killing cells that divide rapidly, tend to block a part of the cancer's biology. So something within the cancer cell that's very specific to the cancer cell, perhaps a mutation or an upregulated protein pathway or other things. And the advantage of that is they tend to work better, but also tend to have less side effects, or not the traditional side effects, but sometimes some other more unusual side effects. Many of the targeted treatments that we use for treating cancer tend to be pills. And that's because many of them were developed more recently than the traditional kind of cell killing. And sometimes we use both. Sometimes it's a combination of traditional chemotherapy drugs as well as pills. It really depends on the type of cancer. And it's very complicated because there are literally hundreds of different cancers. And then when you include subtypes and based on mutations and molecular testing, it can even get into the thousands.
Wow. Okay. Thank you very much. All right. That's helps to really explain how this is. It's a direction of the present and the future, but the other drugs are still important as an option and in various circumstances as well. The next question that I have, I'm going to ask of Dr. Koul. Dr. Koul, you showed the pictures of the radiation machines, and can you comment? And if I'm a patient and I'm nervous about coming in, can I have my family members come with me for my treatments?
A great question. So once you are in a radiation, that big fancy room in the picture, unfortunately, you have to be there alone. You are connected by audio video system to the console area, which is outside of the radiation machine. There's a big heavy door. You practically need like 3 people to close the door. So your family member can stand outside along with the radiation therapist, which we sometimes do because we have some patients who are very anxious, or a young child or elderly patients who just might want to listen to some voices. We can do that. But inside the room is not allowed, and that is for the safety of the family member and the loved ones. When radiation machine is on, radiation is coming. It is very precise, but it does produce a scattered radiation in the room. So we don't want the loved one's family member or even staff member to have those radiation going into them. And that's why all the machine rooms are quite thick. That's for the public safety, but you can stand outside and talk to them. And after a few days, the fear of unknown vanishes. Then patients are so comfortable, they know exactly what to do. But yes, not inside for your own safety.
That's good to know, and it's good to know that we have the opportunity to have people be able to hear, so that there can be somebody can be talking with you as a patient. You can going through it, and so they can be close to you even if they can't be right in the room for radiation. So
correct. And to add on, sometimes patient might prefer a music that has also been requested, or actually a fan just to have that noise. So there's, sometimes patients are a bit more anxious, so things can happen, yes. And we will try to make it as smooth as possible for patients.
All right, thank you for that. The next question that we have had come in is actually one for all our speakers. So we're gonna do a fancy thing and have all of you put your cameras on and maybe just answer this next question, which is it's certainly appreciated that all the expertise that you've talked about and that is available here in Manitoba, but we're curious, do all these professionals network to other professionals in North America and Europe to find a cure? Like, how are we doing? Like, do we work with others, or is the expertise really centralized here in Manitoba?
Maybe I can start. Most medical oncologists and hematologists participate as both a network within Manitoba with other individuals who are experts, but as well as with other experts in Canada and actually throughout the world. Especially given that many of the things that we treat are rare or unusual. It does require sometimes talking to other individuals for that level of expertise. For instance, most medical oncologists, in fact, I think all medical oncologists, are members of the American Society of Clinical Oncology, which is an international group. And all of our medical oncologists routinely attend international meetings, both to be updated about the most current state of research and treatment, but also to network and collaborate with others. Same goes for hematologists. Almost all of them, or all of them, are members of the American Society of Hematology, which serves the same purpose. As well, from a clinical trial perspective, we are all members of the Canadian Cancer Clinical Trials Network, which participates in collaborative chemotherapy studies as well as radiation studies, not just across Canada, but through international collaborative groups. And as Dr. Cuvelier mentioned, we're a member of the Children's Oncology Group, which serves the same purpose, but I can let him speak to that.
Yeah, thanks, Dr. Minuk. So in pediatrics, it is integral that we collaborate outside of our center, and we do. So one of the interesting things is people say, well, when are you going to cure cancer? And I say, well, we already do cure cancer. In pediatrics, we cure about 80% of the children who we see. And you ask why? And because for the last 40 years, many centers, over 200 in North America, have collaborated together to try to develop large-scale research. And so I answer that back and say the only way that we're going to, one, improve upon that cure rate and try to help the other 20% who do not is through collaborative research. And we do, and we prioritize that. And for instance, the precision oncology in young people is exactly that, a large national effort to try to improve the outcomes for the 20% of children who are not cured. And secondly, we can do a better job of curing those who are here, trying to find treatments that are less toxic, less side effects, and still result in good outcomes. So we absolutely participate, and we must. It's integral to what we do.
I'll add to that and certainly agree that everything's been said. I think, first of all, when it comes to common cancers, I think you can be very reassured that the treatment that you are going to get in Manitoba is exactly the same as the treatment that you're going to get in Toronto or New York City or Paris. About half of the patients I treat have breast cancer, and I can absolutely say that because it's so well known, and as a medical community, we are so good at distributing information around cancer that you will get the same standard, top of the line, cutting edge treatment. And on a surgery standpoint, that is the same as well. So all of our practitioners go to meetings and get updated on different techniques and what's happening. And we actually even have a network that an office that I lead and get support, a heavy support from Dr. Turner for, of distributing that information to our community partners as well, both on the surgery side and the family practice side. So we have systems for our doctors to be at the top of their game and give whatever needs to be done, and also making sure that our community partners are equally well supported to give you whatever you need. I started off saying common cancers, and then when it comes to uncommon cancers, those are the ones that are centralized at CancerCare Manitoba from a surgery standpoint as well. And our surgeons are national and oftentimes international leaders. They give talks around the world about what we are doing here. My interest has to do with knowledge translation, which means keeping everyone up to date. So we sit on panels that help create guidelines that guide surgeons across the country as to what the best practice is. So you're in well stead, and just to see, no matter where that care is happening, that we have a system in place to make sure it's the right care.
I think you all already said it same goes for my group as well. We are part of international national networking system. I just want to say that just for the comfort for patient and the family members who are connected today, that we have what we call a multidisciplinary platform, which is a local rounds, which is attended by all the physicians of that disease site group. For example, let's say Dr. Hebbard's breast rounds, they're attended by medical oncologists, surgeon, radiation oncologist, pathologist, radiologist, and any surgeon who wants to connect. They can always pop the question, they can reach to any one of us, and we're always available to help them. Where radiation is concerned, I'm very proud to say that we are leaders in Canada for one of the state-of-art technology, SBRT, and you can browse it. It's capital SBRT, stereotactic body radiation, and we do it for our neighboring provinces as well. And you are in good hands. And as all my colleagues already said, if there's something difficult, we can always email or pick up the phone and call anybody in the world pretty much.
And just to add to that, just wanting everybody to know that the counseling and therapeutic approaches that we provide are guided by the Canadian Association of Psychosocial Oncology. And in my opinion, because we are providing services from any point from pre-diagnosis to diagnosis, survivorship, into advanced treatment and onward, support services for family members, along with the support groups and programming, I think we have one of the best support services available across Canada.
All right, thank you all for that. And then I know there's in the Q&A, there's been a number of comments about how grateful people are to hear about the connections with others around the world as we continue to make advances in cancer treatment and management. Cheryl, I'm going to keep you on this for this next one, and just to answer this next question. Folks, keep the questions coming. I'm hoping we will get to as many as we can, and if we can't, we will do our best to try to find a way of getting answers out onto the website for you. But with respect to your presentation and your work, Cheryl, one of the people writes in that one of their loved ones has an advanced cancer, pancreatic cancer, and is supported by an older spouse, and so is very the person is very concerned about the caregiver's health as well as the patient's health, and just wondered if you could comment on art therapy, mindfulness, yoga, and the moving forward after cancer. Are those kinds of programs available for the care providers as well as for the cancer patients?
Great question for whoever had asked that, and so much attention needs to be on absolutely the caregivers as well, because they are just as affected, and evidence can actually show that they're more affected sometimes in regards to anxiety levels. And so some of these support groups, depending on who is facilitating them, most of them are geared towards the person that is diagnosed with cancer, but some of them we're opening up to more to the caregivers and their families, because sometimes it isn't the person diagnosed that wants to access. And so we do try to accommodate caregivers and family members, and are doing that much more so than we used to be able to do, Dr. Turner.
Thank you very much. I think that's very good news for all involved. So I'm going to try to get two questions in one bundle here, and I'm not sure whether this will be a Dr. Hebbard question or Dr. Minuk question or Dr. Koul. So all of you just be ready. So the first part of the question is, could somebody expand on if you have an earlier stage or an aggressive or slow growing cancer, like what do those words really mean? And related to, as an example, if in the case of a prostate cancer as an example, that even though sometimes your certain markers seem to be coming down, but your risk is still, you're told it's intermediate. So what is this language about sort of, the early stage, aggressive, intermediate risk? So that's a little bit of a bundle of questions, but maybe
I think I'll take it then.
All right, okay, go ahead, Dr. Koul.
Yeah. So prostate cancer is a bit different as compared to what you normally will listen in the community. Let's say you're sitting in a support group of breast or lung. They'll usually say, oh, Mrs. Smith has stage 1 breast cancer, or Mrs. Smith has stage 4 lung cancer. In prostate cancer, however, when you'll see the urologist or radiation oncologist, you'll hear risk stratification, because prostate cancer is done a bit differently. We will get your information, your blood work, your biopsy results, your CT scan, your bone scan. We'll put it all together, and then we'll tell you, okay, you have either low risk, intermediate risk, high risk, or metastasis. All these 4 names are not stages. They are actually risk stratification, which is very different to prostate cancer as compared to other cancer where you'll hear stage 1, 2, 3, 4. So intermediate risk is actually in the middle. It's not low risk, it's not high risk, it's in the middle. So it's kind of a sweet spot zone. In intermediate risk, you have favorable and unfavorable variety, which your doctor will tell you once they will see your biopsy results. They'll see your PSA results, and then they will let you know which category you fit in. The word aggression in prostate cancer often is actually related to your biopsy. They will see the cancer cells, the pathologists, our colleagues, they will compare it to the normal prostate cell, and then they will grade it. Is it really closer to normal cell, or it's like, very rogue, like a teenager not listening to anybody? So they will give the grading of the aggression. So intermediate risk is as per that aggression, which is seen on pathology, but they will keep all the parameters under consideration. And in your clinic, they will let you know, are you low risk, intermediate risk, or high risk? You will not hear most commonly stage 1, 2, 3, which is very common terminology in rectal cancer, in breast cancer, or lung cancer. And I can understand that confusion. That's a bit different.
I think it's a great analogy about cancer being a bit like a teenager, because that is one of the challenges we have, is when the cancer won't listen or respond to both either the instructions of the body to stop growing or to the cancer, to the treatment itself. Maybe I'll just go to Dr. Hebbard to comment on the non-prostate cancer when we're talking about stage.
Yeah.
Can you just a little bit about that?
Yeah, for sure. Stage, and I think Dr. Minuk had mentioned it in his earlier comments as well during his initial presentation. Stage oftentimes reflects where is the cancer in your body? Is it just a small cancer, just confined to the organ that it started in? Has it spread to things like lymph nodes? Has it gone to multiple organs? And for most cancers, there are very few exceptions, but there are definitely exceptions. We do that on a scale of 1 to 4, with the 1s being very early and the 4s being most advanced. So stage has to do with how much cancer do you have? Grade has to do with aggressiveness. So when a pathologist looks underneath the microscope at that cancer, how fast growing does it look? How angry does it look? I oftentimes use for like, how bad does it look for its potential to go to other places? So aggressiveness has to do with the potential for it to go to other places or potentially already be in other places. So stage, how much do you have right now? Grade or aggressiveness, how the potential or angriness of that cancer to go to other places. Hopefully that helps a bit.
All right. Yeah, thank you. It does a lot, I think, and there's been some questions in here around staging, and I think the description around staging, there are some similarities between some cancers, but there are some differences too in terminology, so that's helpful. I'm going to keep Dr. Minuk on for this next question, which is there's a question about is a combination of oral and infusion chemotherapy better or more effective than just having one?
Yeah, I wouldn't say one is better or worse, just different. And again, there's hundreds of different iterations and permutations of chemotherapy drugs, IV alone, pill alone, combination of IV and pill, subcutaneous injections, so a needle under the skin, cellular therapies, including stem cell transplantation. It's not better or worse, just different. And our decision to use these is guided by research and clinical trials. So basically, clinical trials will compare what was considered the standard treatment to a newer treatment to see if that newer treatment is better. And if that clinical trial shows that that newer treatment is better than the older treatment, irrespective of it's of a pill or an injection or a combination, that newer version is what we start using.
Right, thank you. And actually, Dr. Minuk, I'm going to keep you on because there's another question that I think is very related to the sort of work that you do, especially when we're talking about systemic therapy treatments that cover everything. It's sort of a two-part question, actually. The first is if you can talk about the difference between chemotherapy and immunotherapy. And also, how do all these things tie into, like, do we do genetic testing for mutations? It's like, are we doing this thing called precision medicine? And, you know, when are we going to start doing precision medicine? So the first part, though, like, the difference between chemotherapy and immunotherapy, and then what about this thing called precision medicine, and when do we expect it here in Manitoba?
Yeah, those are great questions. Chemotherapy, as I alluded to before, is generally considered drugs that kill rapidly dividing cells. Targeted therapy is drugs that interfere with some kind of pathway that is abnormal, specific to the cancer cell. Immunotherapy is a relatively new concept where we harness the body's immune system, which already has an innate ability to surveil and kill cancer cells. So all of our immune system, as well as protecting us from infection, also can pick up on cancer cells that naturally develop and get rid of them. So there are drugs that can be used that actually ramp up the body's natural immune system to actually start killing cancer cells, and that we call immunotherapy. The question about targeted therapy and genetic testing, the answer is yes, we do that kind of testing here. We actually have a genomics program at CancerCare Manitoba and what's called a next generation sequencing platform, which is the state-of-the-art technique for identifying certain genetic mutations that are present in cancer cells. This is necessary for both helping us diagnose cancer, provide the right classification for it, but also in some cases, providing targeted treatment for that particular cancer. And as clinical trials, again, tell us that a certain mutation is important to test for, whether that be from a prognosis perspective or to guide targeted treatment, then we incorporate that new mutation into our testing platforms.
Right, thank you. So it's great to know the future is now for many cancers, although I do know that that there are things that we're finding out. There's more and more opportunities for precision medicine as we identify more targets and for testing and the drugs that go along with them. I'm going to ask one last question, and I'm wondering, we haven't heard from Dr. Cuvelier for a while. Dr. Cuvelier, this isn't exactly a pediatric oncology question, but I wondered if you could comment in the same way we were just talking about stage, the use of the term, the difference of terminal and not terminal diagnosis. Can you sort of explain sort of generally what that means when you're speaking to a patient, is there sort of a continuum? Like how does that work?
Yeah, so one of the it's a good question, but one of the challenges is that when we meet when we make a new diagnosis, I think that the term terminal here is, am I not going to survive ultimately this cancer? And sometimes that's a very difficult question to answer. So, for instance, there are some cancers where one would say you have a lower percentage chance of surviving it, and some people are going to survive it. And there's others where one would have a very high chance of surviving it, and for whatever reason, they don't. The term terminal, I'm not sure I like the term. I think that the term is probably better that all of the various treatment modalities that are realistically going to cure an individual have been tried. And at this point, there isn't a realistic chance that somebody's likely going to survive their cancer. And we need to shift how it is that we're actually managing. That doesn't mean that we stop seeing patients. We continue to see patients. We may try treatments that may prolong life as opposed to curing the cancer. And we certainly want to make sure that we do things that help people's symptoms, because really, and to try to improve their quality of life. And that may be pain management. It may involve surgery or radiation still to try to help take out tumors that may be causing problems. It may involve additional chemotherapy or immune therapy agents that prolong life. It may involve anti-nausea medications. And it may involve bringing in additional colleagues who maybe work for our pain and symptom management team to help on out, to try to improve an individual's quality of life. The term non-terminal, I guess, would mean the opposite, that we are fully expecting to cure. But again, I don't like the terms because it implies that it's a yes/no answer, and that's not always exactly what happens.
All right, thank you very much. So I've tried to manage most of the questions or fit them all in. I think I probably, unfortunately, have to miss a few, but thank you all for participating tonight. So thanks very much for the presenters, and again, apologies for those that we couldn't get to. But please do be in touch with your healthcare team if you have questions, or a nurse navigator with other questions you might have. So we are hoping to have a recording of this event up on the CancerCare Manitoba YouTube account as soon as possible. Our YouTube account is called CancerCare MB, all one word. And thanks for the presenters for sharing time and knowledge with us tonight. And we really appreciate that. And we know we couldn't hold an informational event without informational experts. Thanks also to our community partners for providing photos of their sites, especially Ronald McDonald House Charities here in Winnipeg. And thank you, all of you who are attending, whether you're in Winnipeg, rural or northern Manitoba, Kivalliq and Nunavut, or elsewhere across Canada. We seek to continually connect with patients and their loved ones to help close the communication gap. And we're really grateful you could join us tonight. So that marks the end of the webinar. We will play the World Cancer Day navigation video one final time for anyone who may not have caught it. And then we'll close the Zoom. Have a wonderful evening and take care, everyone.